I wrote to Dr. Burt because I read his book and he said when it's a SPMS, it doesn't work.
The doctors now are doubting that it's going to secondary progressive.
And when I start to drink Ocrevus, I have symptoms like my legs don't work anymore.
And if I do transplantation, would you suggest to start any treatment before coming to do the transplantation? Because for now, I don't have any treatment ongoing in my body.
What happened for the 30% for whom it doesn't work? Can they get worse?
And do you make some additional or recommended tests to be done here in our country?
What is the difference in terms of risk to switch from RR MS to progressive MS if I do treatment or if I do transplantation?
And do you have patients that go home without having the transplantation because you decided not to do it?
Hi dear friends, welcome to Moscow. Right now we all are here together.
So beautiful, Anastasia is here. She will help in our discussion and our webinar.
And of course we have our friends who want to ask questions. We are ready. And Emmanuel will be the first lady who starts today with questions.
Welcome. Hello, Emmanuel.
Hello, doctor. Well, the first question I have is, well, I'm a 58, almost 58 years old woman. I think I had SPMS for 30 years, almost, probably, without a lot of lesions, but at least 2 lesions in the spinal cord, 2 big lesions in the spinal cord. And my question is, well, and I started Kesimpta last August because I had 1 new lesion last January, January 24. So basically, if I read correctly and if I understand properly what you said, I'm in the group of, quite an intermediary risk group, I think. That's what you said. I'm 58, 30 years of SPMS, 1 new lesion, one new lesion last January 24, and under Kesimpta that I just stopped because I'm really thinking about HSCT. But another thing, I wrote to Dr. Burt because I read his book and he said when it's a SPMS, it doesn't work. If you haven't got any new lesion, it doesn't work. So basically, I wrote him a mail and he answered me, it is not going to work. What do you think?
Okay, very good and very important questions. Okay, we are in contact with Dr. Burt and we are friends. We meet each other in Florence. So when Richard Burt published his book, we didn't have too much information about effectiveness of transplantation. In the next book, when Richard Burt, Dominique Fudge, John Snowden, this is textbook of transplantation for autoimmune disease. There is a special chapter, this is 2nd edition, transplantation for progressive multiple sclerosis. What can I tell you now? This prognostic group also statistic and combine many patients. For example, high risk group, this is 40% from 900, so this is 200 patients, but MS is a unique disease. Each patient with MS is different. Actually, there are no 2 similar patients. So it's true to say that there are almost 3 million variants of MS. And we should make decision personally. The most accurate decision is personal decision. This is science, this is statistic. We try to systemize our result, especially when we work with big data. But personal decision is the most important thing. What about your situation? If we look to high-risk group, 60% of success is much better than 10-15% of anti-B cell therapy like Kesimpta. Another thing, patient has to use Kesimpta all time, delaying the disease, slowing down. Transplantation can be done only once without any further treatment. What we recommend in situations like yours? If patient has stable disease, no ADSS worsening, no new lesions, and secondary progressive phase, you're absolutely right, and I agree with Dr. Bird, we can wait. But your situation, you have one lesion, new lesion in spine. It
In
means,
January 24, sorry.
so you have new lesion in spine. 1 year ago, a little bit more than 1 year ago, it means that your MS is getting down. Our position about spinal lesions is very important because spinal lesions are related to quicker progression and to high disability level. So, other words, the more lesions in spine, the quicker progression of MS. In situation where ADSS is decreasing for 1 year, we recommend transplantation. Also, situation if patient starts to have new lesions in spine with or without ADSS WOS, we recommend transplantation. We don't recommend only if patient is stable 1 and more year in progressive variant. Also, if patient doesn't have new lesions in brain and spine, especially in spine.
It was in brain last January. It was a small one in brain. I just felt a weird sensation on my cheek.
Yes, so also spinal location is much more important, but if you have new lesion, you still have inflammation. Transplantation effects on inflammation. Also, it's very important to see, does patient have signs of brain and spine atrophy? If patient has brain and spine atrophy on MRI, we don't recommend transplantation. So if you make decision to go to transplantation, welcome. We repeat all tests and we make personal decision together with you. Actually, we discuss with Neurological Society anti-B cell therapy in progressive variant. Nobody knows how it works because MS is more T cell related disorder.
Yeah, that's what I understood.
Of course, B and T, but more T. Kesimpta affects B cells. Transplantation reduces T and B cells. So if patient has inflammation, it doesn't matter, relapsing, remitting, or primary or progressive variant, we better decrease inflammation, affecting all wrong immune system. Of course, Kesimpta helps, but not halting, but decreasing inflammation. Transplantation can halt it. So, of course, your decision isn't very easy and you are not ideal patient based on our prognostic group. But if we compare anti-B cell therapy with transplantation, we have results which are much, much more effective.
Yeah.
What about age? You are young. The oldest, you are young.
Thank you.
The oldest patient we transplanted successfully was lady from London. She celebrated 70-year-old 1 month before admission to our hospital. Also progressive MS and transplantation was successful.
Okay. What about Kesimpta? How long do I have to stop it for?
3 months before is enough.
That's enough. Okay, because
3 months.
I just stopped it.
Yeah, 3 months is enough.
Okay, so but it's still very scary. How do we manage it? I mean, do I have to sign for a transplantation without being sure that it's going to be done?
But transplantation can be done only once, not as a treatment after. And of course, every patient with MS has autoaggressive T and B cells. Of course, Kesimpta decrease MS progression. And unfortunately, we have many patients anti-B cell therapy who failed it after 1, 2, maximum 3 years. Of course, in your situation, there are two options: to do it now or to wait 1 or 2 years to see. But 90% that Kesimpta only delay MS progression but won't stop it. So of course this is your decision, but my position is to help make your decision. To make a decision, I am on your side. Of course, I am not going to push you to make this decision. We can analyze risk and benefits, mainly in our hospital. Of course, if your last MRI you had January 24, you can repeat. We recommend to have MRI once a year. Maybe now the time for new MRI.
But I had once, I think last October, yes, and there was no change after January 24th. So I don't know what to think about it. Is the answer in the progression between the first MRI and the last MRI? Like, for example, if I have in 4 years, would you be able to see if there is a progression in the lesions that were present like 4 years ago, and now can they change a little bit?
Sometimes it's complicated to compare, especially different machines, but the most important is your symptoms and your disability level.
It's getting worse. The disability is getting worse.
If it's getting worse, put on the first place your condition. MRI is the second place, because sometimes patients from running to wheelchair never have new lesions. They down with stable MRI from running to wheelchair. Because MRI is limited to detect damage on cellular on very low, on very small level. So some patients, especially with primary MS, have stable MRI all MS cause.
Okay, I understand.
So
another question, see if I have time, just what happened for the 30% for whom it doesn't work? Can they get worse?
No, only the same cause. Only the same cause. Transplantation can't make worse. Also, 100% it will stop it. But this is 30-40%. MS will start to progress with the same rate, usually in 2-3 years after. It will be temporary effect, but we hope it will be very long effect, maybe for whole your life. But transplantation can't make worse for progressive MS because modern protocol is very safe, almost zero toxicity.
Okay, and just another thing, why using rituximab if it just kills B cells and not T?
The main effect is based on chemotherapy, because combination fludarabine with cyclophosphamide remove all T and B cells. We use rituximab because B cells recover quicker and can cause Epstein-Barr virus reactivation. Using rituximab, we additionally deplete B cells. Also, we prevent Epstein-Barr virus reactivation. Actually, the main idea of rituximab to save patients from Epstein-Barr virus reactivation, because the next step after reactivation is MS relapse. Epstein-Barr virus can be a trigger of MS. So this is additional protection and maybe additional minimal immunosuppression. But of course, the main treatment effect is a result of combination of chemotherapy. Without chemotherapy, rituximab can't work at all.
Yeah. Okay, so rituximab could kill the virus.
Could kill, could decrease amount of healthy B cells which repair very quickly, and all we have Epstein-Barr virus in our body. And after very strong decreasing of immune system, Epstein-Barr virus can reactivate and attack new healthy B cells. This is like a target, like food for Epstein-Barr virus, home for Epstein-Barr virus. So, and can be reactivated. So if we delay B cell recovery, we protect body from Epstein-Barr virus reactivation, and it's not a kind of MS treatment. This is a kind of better immunological recovery after chemotherapy. More optimal recovery after chemotherapy.
Okay. And do you have patients that go home without having the transplantation because you decided not to do it? Does it happen?
It happens sometimes, but more often it was two disabled persons with stable long MS, with high disability level, and with lots of brain and spine atrophy on MRI. Sometimes we receive documents which is quite old when it is 6.5, and then we have patients who can't move, eat, completely disabled, and this situation is quite long. Very rare we had situation that we find some other problem, healthy problem, which can, like more serious disease than MS. This is cancer, for example. But firstly, we need to treat cancer than MS, but it's quite rare. Also, if patient tell us, doctor, this is your opinion, this is my opinion, let's discuss, I want to watch and wait, let's make second test and second reassessment in 1 year. It's also possible.
Okay. My other question was just, is it possible right now to repair lesions with mesenchymatome? I don't know how you call
mesenchymal stem cells can't repair lesions. It can. Mesenchymal stem cells are not proof in many countries, including in Russia. Mesenchymal stem cells can, like immunomodulators. Mesenchymal stem cells do nothing for MS at all. What is the future? This is recent Japanese research of modified multipotent stem cells.
Yes.
Yes, this is Nobel Prize, I think 2012. This is future because this is stem cells which can repair nerves, but not mesenchymal.
Not neuronal stem cells.
Yes. But this is only clinical trial, only adult research. Maybe it's future. But to reach this future, we need to stop autoimmune process. And the place of transplantation is here. Also, if you want to repair nerve system, we need to stop destroying process. This is like a fire. The earlier we stop fire, the less we need to repair.
Okay, thank you very much. Thank you very much.
You're welcome. Good questions. Thank you. Have a nice day.
Thank you very much. You too.
Thank you.
Thank you, doctor. Really very good questions, very serious questions. And it's again a question about how it's difficult to make a decision even to do transplantation, about future maybe life. So
I think we answered questions of many patients because it was very important questions and covered many topics.
That's true, even for me, some new information. So anyway, doctor, let's continue. We have another nice lady, Ines. She also has some questions. Let's start.
Hello from Croatia. I have questions. I have RRMS. I have Epstein-Barr virus, and for 3 years I don't have new lesions, but clinically I'm not very well. I can walk only 100 meters without stopping, and it's only for a 5 minutes stop, and I can walk again 100 meters, and I need to stop again. I don't have new lesions for 3 years. Is that normal?
Okay. May I ask you two important questions for me to answer your question? Firstly, if you compare your condition now and 1 and 2 years ago, are you better, worse, or the same? If your 3-year
I
dynamic of
I
your
had
condition,
diagnosed 4 years ago, and I had Ocrevus, and when I start to drink Ocrevus, I was I have symptoms like my legs don't work anymore like they used to do. I had ritmička sportska gimnastika and training in
it's
young
great.
years, and I'm sport tip, but I can't do the sport anymore. It's
Look, my question is, if we analyze your 3-year dynamic, your MS is getting down.
yes.
Your MS is getting down.
I'm worse. Clinically,
you're getting worse without new lesions.
Yes.
Did you
Clinically, I get worse, but no lesions, no new lesions.
when you had MRI, did you check your spine, neck and thorax?
Yes.
All
yes.
spine.
Yes.
So
Yes.
did you have
And
lesions in spine?
1 year, I don't drink any pills, any. I just don't eat sugar, red meat, milk, and milk products, and I feel little better, but not very well.
Okay. When we analyze clinical situation, we have two big important things. Medical assessment, this is neurological status, and MRI test. And patient reported outcome, this is your personal condition, your symptoms, your quality of life, how you feel. And we need to combine both. If you are getting worse without signs of MRI, new MRI lesions, your MS is progressing. Because as I told answering previous patient, some patients with MS never have new lesions. From running to wheelchair. From year to year, they are getting worse. And the reason is
That's me.
MRI is limited to detect inflammation on very small cellular level. So this is why our position to provide transplantation based on clinical picture. So in your situation, we recommend transplantation because your MS cause is quite typical, is going to change course from IMS to SPMS.
Okay.
There is a high risk to have secondary progressive MS in closest years.
If I decide to come to the therapy, how long therapy is? How long I need to be in Moscow?
1 month.
1 month. And how much it costs? Therapy.
I think it's better to discuss with our administrations because I'm responsible for medical part. So all organized questions about visa invitations, tickets, and other. We have special departments. Anastasia is also responsible for organization. They will answer. Today our topic is medical issues. So, but
do you think I'm a good patient for that therapy?
Yes, because you still have RRMS, relapsing remitting MS.
I still don't walk with a stick.
This is very important thing. We need to do it now to protect you from stick and further disability. You are still
after the therapy. After the therapy, do I need drink some medication?
No disease modifier drug, only vitamin supplements if you want, like vitamin D, but no special MS treatment.
Okay, so after the
No
treatment,
Crevus, nothing.
thank you very much.
You're
You
welcome.
answer all my questions.
You're welcome. Thank you for good questions.
Nice, doctor. Again, more information for others as well. So, anyway, let's continue. We have another nice guy who also wants to ask you some questions. Laurent, welcome.
Hello.
Yes. Hello, nice to meet you from France.
Nice to meet you.
Well, I just give you a little bit the picture of my case. I'm 40 years old. I have been diagnosed for MS RR 2 months ago, and I have 2 spinal lesions and 30 lesions in the brain. Until now, I had only 1 relapse because it's 2 months only. And I did not start any treatment, such as Kesimpta or Ocrevus. They proposed me at the hospital, but I was thinking about it. But some friend who did the treatment in your hospital told me about you. So I am still thinking about what to do because it's quite new. And to be honest, I feel not sick. I feel normal. I do sport. I do exercise. So I feel quite normal. So my 2 questions are the following. Would you suggest in my case to do transplantation or not? And if I do transplantation, would you suggest to start any treatment before coming to do the transplantation? Because for now, I don't have any treatment ongoing in my body.
Okay, good questions. If you saw my presentation and our result we presented in Florence 1 month ago, treatment-naive situation where patient didn't have specific treatment before is one of the most positive factors associated with better result. If you analyze your personal case, you are the best candidate for transplantation. 40 years old and younger, relapsing remitting multiple sclerosis, low ADSS, no disability at all, no previous treatment, and good quality of life. 4 factors. So for transplantation, it's good. You have 2 choices: to start anti-B cell therapy, which is less effective, and to do transplantation. And of course, after transplantation, you won't need to have any specific treatment. This is good, but what is the most important thing I want to tell you based on your history? And we have the biggest single center experience of transplantation for MS. And this is also not from me and our experience. This is also a kind of neurological rules. If patient has spinal lesions in the beginning, risk to go to secondary progressive stage is higher than only brain damage. So spinal lesions in the beginning, when MS only started, is an favorable factors, because MS is quite unpredictable. Some people live 30-40 years without any problems. Sometimes MS is very aggressive, sometimes slow and then aggressive. The main cause of relapsing remitting MS, traditional, not slow, not aggressive, from good condition to bad condition, 10-15 years. Quicker with patients who have spinal lesions in the beginning, and slower for patients without spinal lesions. This is addition. This is not bad and not good. This is only fact and give us information that you need to start with effective treatment. Anti-B cell therapy is effective. Transplantation on the top. So our position, my position like hematologist, to give this treatment as soon as possible, especially for people with spinal lesions in the beginning. So I recommend transplantation. But this is your choice. Another option, to start anti-B cell therapy 1-2 years, to have good MRI control, and to switch to transplantation in case of low effect of anti-B cell therapy. So, but you should start any treatment. In neurology, the most effective treatment is anti-B cell therapy like Ocrevus, Kesimpta. So this is why they recommend to start it, because of, I think they also know about risk of spinal lesions. Because anti-B cell therapy in neurology, this is the most effective treatment, one of the most effective treatment. Transplantation, only transplantation more effective than anti-B cell therapy. So two options. We recommend transplantation. Of course, if not, start anti-B cell therapy, and then if effectiveness isn't enough, go to any hospital, to Moscow, to another transplantation center, but please don't change one anti-B cell therapy to another. In your situation, you should intensify your treatment. If you start with like Ocrevus, Kesimpta, and effectiveness is low, your patient failed this treatment, go right to transplantation. Or another option, start transplantation, 1 month treatment, and then only observation. Options.
But what is the difference in terms of risk to switch from RR MS to progressive MS if I do treatment or if I do transplantation?
Risk to have secondary progressive MS is quite high if you start with anti-B cell therapy, because MS is mainly T cell therapy disease. B and T, but mainly T. Every neurologist knows that MS is related more T cells and B cells. And if we reduce B cells, we only delay problem. High dose chemotherapy, when we use during transplantation, remove T and B cells. The differences between two approaches: anti-B cell therapy decrease amount of PAT, autoaggressive immune system. Transplantation destroy all wrong immune system and rebuild healthy one. This is why so different result.
Okay, and what is the risk to do the transplantation?
If we use modern protocol, 0. No secondary malignancies, no secondary autoimmune diseases. Risk was much higher for old myeloablative protocol. For new lymphoablative protocol, risk is quite low. But if you want to do some research, you can Google in the internet, because it was clinical trial. I think in 2012 or 11 published in JAMA Neurology, but you can make search, it's quite easy. It was a randomized trial. 55 patients with relapsing remitting MS received transplantation, and 55 patients received the best available treatment, mainly monoclonal antibodies like anti-B cell therapy. In 5 years, only 3 patients progressed in transplantation group, and more than 30 patients progressed in disease-modified group. It's published. It was not one country trial, it was international trial. You can find this article in the internet. If you can't find, be in contact with Anastasia, I have this article, we can send you.
Okay, thank you.
This is not our article, this is Europe together with the USA.
Okay.
Big clinical trial. So you can provide some research to make decision, or make your decision you feel by your heart. But my medical opinion, transplantation is the best for you.
Okay. Thank you for your time and your advice. Thank you.
You are welcome.
Thank you.
Thank you a lot again, doctor.
Yeah, well.
There's lots of information, very helpful for all of us and our friends at first, of course.
If you have requests from him, you know this article or not, I will send you. It's quite popular article which compared traditional treatment with transplantation for relapsing remitting early MS, and proved that transplantation is almost 10 times more effective. So also Richard Bird is one of co-author of this article. I have it on my computer.
No, super. We will share maybe again with for other patients as well.
Yes,
That's
yes,
nice,
yes.
doctor.
Because
We'll update. Anyway, we can continue. We have also friends who have questions, and I think ready to do it.
Hello.
Yes. Hello, doctor. Good evening.
Hello, nice to see you. Good evening.
Yes, I'm just a few words for me. I'm 44 still. I was diagnosed in 2017, since 8 years, with rare MS. But the doctors now are doubting that it's going to secondary progressive. I have spinal lesions since the beginning, but with no change or increase in number since 2017. Okay, my EDSS is about 2.53, something like that, but I'm still active, physically active, walking and doing some sports. But yes, I feel a lot of fatigue and, of course, difficulty walking long distances, more than, for example, kilometer or something like that.
Okay, thank you for
Yes, and I have never been on any DMT till now. Only twice I have corticosteroid therapy.
And did it help you? I mean, corticosteroids?
No, it doesn't help.
Okay,
Didn't.
so this is very important situation because spinal lesions and non-effectiveness of steroids is quite typical for progressive MS.
Yeah.
This is what I told before. Spinal lesions in the beginning usually cause to more aggressive MS course, quicker course to from relapsing remitting to secondary to switching course of MS from RR to SPMS. So this is why we recommend to do this treatment as soon as possible in situation with spinal lesions in the beginning. But your situation is very good. I think maybe you are not still really in secondary progressive course because changing course from relapsing remitting to secondary progressive sometimes takes time, not months but years. And for secondary progressive course is quite typical to have a DSS more than 5.
More than 5, yeah.
Important thing is if you compare your condition now and 1 year ago, are you getting worse or not?
Yes, I am. I feel.
If you are getting worse, you need active treatment and better transplantation because for progressive variant of MS, traditional treatment isn't effective at all.
Yeah.
Another thing, why MRI is very weak to detect dynamic in spine. Spinal dynamic can't be assessed by MRI carefully. This is why on the first position in situation like yours is clinical cause.
Yes.
Really, fatigue, to be honest, fatigue is the most troubling symptoms of MS. Many doctors don't know about it, but I think I am right. You wake up tired.
Yes, exactly. And doing some really light homework or house stuff, something like that, is I need to lay down for a moment
tired,
just to relax.
Tired. But your fatigue can be improved by rest, and this is very important because this symptom is related to autoimmune process, and this symptom can be better after transplantation. But of course, the most important idea to save you from high DSS score. If we stop it right now, and of course we can improve your quality of life, actually transplantation, why we recommend to do it as soon as possible in progressive variant? Because we can stop MS to prevent further disability. And we usually can improve condition to condition patient had 1 year ago. You can imagine your situation 1 year ago, and this is how we can improve. Sometimes we can do more, but common rules, if your DSS was 2, now 3, we can send you to 2 again.
Yeah.
If you this is 6, 2, and 3 years, we can keep 6. This is
Yes.
common rules. So this is why you are a good candidate for transplantation.
And do you make some additional or recommended tests to be done here in our country for to exclude other autoimmune diseases?
No, we can do it in hospital. We are not private. We are big university hospital. We provide complete body assessment, general health. Also, we provide brain and spine MRI with contrast using special MS program. And it will take 2-3 days for complete assessment. So not necessary to do it beforehand if you make decision to admit to hospital.
Okay, great. So everything could be done there. And
Yes.
And anyway, if I decided to come, we could make another discussion for just to finalize the thing. Yeah.
Be in contact with Anastasia. She will help with organization. Also for medical question, I am open. You can schedule private talk with me using WhatsApp call, video call, no problems at all. If you have any additional question, we can discuss it privately.
Yes, thank you so much.
You're welcome.
For your expertise.
Thank you. Thank you, doctor. Again.
You're welcome.
But I have small surprise for you. We don't have any more patients who have questions. I think it's because patients are very highly educated and know maybe more than we know.
I think we answered. We had so important and so many and very wise questions. So we covered many questions from other patients. So and also after recording and this webinar will be available for other patients. And I think my position, if we can help only one person to make right decision to stop MS, we can do 10 webinars.
That's true. But anyway, we are happy to share experience. It's the most important. People know about our work, and it's good and important for us.
Okay, thank you very much, Anastasia. And firstly, the main idea was to share our experience, presenting our result on the biggest conference in the world in Florence, receiving a high assessment of our activity, and finding lots of topics for cooperation with Europe and the USA in future. Also, the second, which I think may be more important, to ask some questions of our friends, patients who have ideas about transplantation, because sometimes to make decisions is very important and very difficult. We need to have lots of support in this time. So, and if Anastasia, if somebody has private questions, we can discuss time and do it privately, no problems. We are available all time for medical questions to me and for Anastasia for organization. So I think we can do it anytime. And thank you very much. I wish all our friends the best time.
And very nice holidays ahead.
And very nice holiday. Good. Thank you.
Bye-bye.
Bye-bye.